Okay, good afternoon, everybody. A few more people are still drifting in, but I thought I'd just kick off with a few introductory remarks. My name is James Banks. I'm a professor of economics at the University of Manchester, a co-director of the ESRC Centre for Microanalysis of Public Policy at the IFS. And most importantly, I'm a trustee of the Nuffield Foundation. Nuffield Foundation is an independent charitable foundation that funds sort of diverse research to inform social policy across our core areas of welfare, education and justice. And I'm delighted to chair today's webinar, where we're going to be hearing from Daisy Fancourt, who led the COVID-19 social study, which was the largest study in the UK to examine the psychological and social experiences during the pandemic. Before we kick off, and I turn to Daisy, I just want some housekeeping announcements. We are all in a big Zoom room here today, but the attendees will not be visible or audible. It will just be Daisy and I. Daisy is going to speak for around 35 to 40 minutes, and so we will have time for discussion and Q&A after Daisy has made a presentation. If you'd like to ask a question, please do so by typing your question into the Q&A box below. You can submit these questions at any time during the webinar. You can also upvote other people's questions if you're particularly interested in the answer to that one. I'm going to keep an eye on this, and I've also got the list of questions from those of you who submitted questions to us in advance when you replied to the invitation. So those of you don't have to submit those one questions again. I will use that set of questions as a basis for the Q&A. I should also say that the chat box is open if you have any wider comments or thoughts, but I won't be monitoring that. There will be some Nuffield staff posting links in the chat box as we go through, which you can look for. We've all got very good at Zoom in the last 3 years, but monitoring two boxes is too much for me. So if you've got questions, put them in the Q&A box. Finally, we have live closed captioning in English today. So to turn it on, please click the CC button along the bottom of your Zoom screen. And the webinar is being recorded and will be available after the event on the Nuffield Foundation website, as will be the slides, if you want more details of the slides. So let me turn to our speaker and presentation. I remember sitting in this very kitchen in March 2020, within a couple of days of the announcement of the first UK lockdown. I was on a Zoom call with the other Nuffield trustees and the Nuffield executive, where we were discussing not just how we could support the foundation as it had to start working in the pandemic, but also that as a nimble research funder, we had like a unique opportunity to fund rapid but still rigorous research into the ever-evolving social and economic situation. We put together a special funding call within weeks, and in 2020, in fact, we responded by awarding almost £2.5 million in fast-track funding to capture many real-time data and insights into the social and economic impacts of the crisis as it was evolving. The COVID-19 social study was one of these grants, and we were delighted to have the opportunity to fund Daisy and her team to design and deliver this important research. So Daisy Fancourt is Associate Professor of Psychobiology and Epidemiology at UCL, and she now heads the Social Biobehavioural Research Group there. Today, as the data from the study become publicly available for the research community, Daisy is going to be providing an overview of the main findings over the whole 2 years, the impact of the study in helping the government respond to the pandemic, and its influence on people's daily lives. A final report from the project which delves into the findings has just been published, and a link to that is also available in the chat. So without further ado, I'm going to pass over to Daisy, who's going to speak for 35 to 40 minutes.
Wonderful. Thank you so much for that introduction, James. And it's a real pleasure to be presenting to you today on the findings from the COVID-19 social study. Early on in the pandemic, we started seeing daily cases and deaths from the COVID-19 being published. But we quickly realized at UCL that this was only telling part of the story, and the pandemic was going to have profound psychological and social effects that we felt needed to be studied in real time too. So this was what motivated us to launch this study, and we quickly recruited over 72,000 participants to take part. They engaged in weekly surveys that they completed for us across the first 6 months of the pandemic, before being randomized into 4 groups who then undertook monthly data collection for the following 14 months, split across different weeks of the month. And then we completed final follow-ups through to March 2022, giving us an entire 2-year span. So in total, this yielded over 1.2 million surveys, as well as over 30,000 written testimonials. And we also carried out over 400 telephone interviews with particular vulnerable or marginalized groups whose experiences we felt might not be captured through our survey. We undertook a broad range of topics within the survey, which included things to do with experiences of COVID or attitudes towards COVID and the regulations, mental health, adverse experiences, social and health behaviours, and time use. And these were asked every single time participants responded, so we could track changes longitudinally. But alongside this, we also have bespoke modules that we delivered one-off or just a few times that gave us more detail on further traits and experiences that individuals had. And we supplemented this with very rich demographic data as well. Because our aim with the study had been to provide this real-time data analysis, we made sure that we published weekly public reports highlighting how we were seeing changes day by day, week by week in our core psychological and social measures. But on top of this, we also undertook continuous analysis of the data that went into over 100 different scientific papers and preprints. And we also provided bespoke data analysis to a number of different government and healthcare bodies, including the World Health Organization, throughout the pandemic. And we also wanted to make sure that the public felt informed about the psychological and social consequences. So we worked very closely with the media, contributing to over 1,000 different media pieces across television, radio, podcasts, and newspaper articles. Another thing that occurred to us very early on was that we weren't the only country that was going to want to run a study like this. And we felt it was really important that we were connected to other longitudinal mental health studies that were either already set up prior to the pandemic and undertaking new data collection, or that, like ours, were being set up as bespoke data collection for COVID. So with the support of Wellcome Trust, we founded something called the COVID Minds Network, which was a network of 170 different longitudinal mental health studies across 60 countries. And with all of these partners around the world, we shared resources, we pooled expertise, and we've also been conducting cross-national comparisons of findings. So given all of this data and collaboration, there's obviously far too much for me to be able to summarize in one event. So that's why this week we published an 86-page summary report that details all of the key findings from the study, acting a little bit like a signpost or reference guide to the individual papers and reports that have emerged from COVID-19 social study. And today I'm going to attempt the Herculean task of summarizing this into 35 minutes. So I'm going to warn you, it will be whistle stop, but you can always refer back to these wider resources and papers to see the detail of things. I thought I'd focus on 5 of our core topics that we looked at in the study, so mental health, inequalities, behaviours, long COVID, and compliance. And then I just briefly touch on the impact and overall learning that we've had from the study. So let's start off with mental health. How has mental health been affected by COVID-19? There was a paper that was published in The Lancet last year, which looked at data from 204 countries, looking at the global prevalence of major depressive disorders and anxiety disorders, comparing before COVID to during COVID. And what this found was that in the first year of the pandemic, the global prevalence increased by about 25%. And the UK was sort of bang on average for this. Specifically, if you look at this map at the bottom, this heat map, you'll see that there is a general pattern here that the countries that were worse affected by COVID, which are shown in the reds and oranges, tended to have also had higher levels of percentage change in depression and anxiety. But this relationship between the mental health effects and the pandemic itself was something that we explored as part of the Lancet COVID Commission, which I sit on. So we undertook analyses from 17 countries specifically that had different levels of pandemic intensity, but also had different levels of policy stringency that they'd had to bring in to control the pandemic. And what we found was that countries that had followed, that had been worse hit, so they'd actually had higher levels of cases and deaths, and as a result had to implement more social restrictions. They had worse mental health and poorer well-being during the pandemic, whereas countries that had followed a virus elimination strategy were able to keep virus levels lower and keep social restrictions lower as well. And this actually meant that they overall had better mental health. But what we wanted to know within this was just giving us a broad brush approach of before to during the pandemic. We wanted to know how that had actually changed week by week and month by month as things have evolved. And that was what our data from the COVID social study was able to tell us. So in this graph, you can see levels of depressive symptoms shown in blue and anxiety symptoms in red across the pandemic, month by month, from when lockdown first came in March 2020 through to the spring of this year. And alongside this, you can see levels of policy stringency, which are shown in this dotted line at the top, as well as cases, which are shown in these bars, and deaths from the virus, shown in this hard line. So as you can see, there were fluctuations in mental health, starting from an initial peak of symptoms that have since been shown to be higher than average levels when first lockdown came in, but with peaks and troughs emerging over the following 2 years. What you'll also notice is these peaks and troughs remained more prominent for depressive symptoms, but actually started to flatten out more for anxiety symptoms. And this got us thinking about what the drivers of mental health were during the pandemic. We were able to look at a broad range of different factors, some individual and some societal. And for this analysis, we looked at a combination of effects during the first 6 months of the pandemic, so that covered lockdown 1 and the easing of lockdown 1, alongside effects during the second phase of the pandemic, so when we had lockdowns 2 and 3, and then the relative freedom period that followed from the summer of last year. Now, as you'll see, there were some factors that acted clearly as consistent predictors of mental health during the pandemic. So, for example, having low confidence in the health services, low confidence in governments, and also low social support. These were associated with higher levels of depressive symptoms and anxiety symptoms. But there were other factors that seemed to be dependent on the specific situations that were occurring within society. So, for example, we found that increases in policy stringency, so the kind of social restrictions that were being brought in, had larger effects during the 2 periods that saw lockdowns compared to the relative freedom periods. So in other words, what we were seeing here was that increases in policy changes became more damaging as they infringed more on social freedoms. In other words, there wasn't a proportional response. Long-term, low-level social restrictions actually had little impact on mental health, but a big impact on virus containment. But when virus levels got out of control and we had to bring in stricter social measures, this was when mental health started to be particularly affected by those measures. Similarly, we found there was quite a nuanced picture around the pandemic intensity. So actually, if we look at the levels of COVID deaths that were happening day by day and week by week in the country, we can see that higher levels of COVID deaths was initially associated with higher levels of depressive symptoms. But actually, this effect was attenuated over time, particularly after the vaccine rollout, presumably because COVID was then seen as less of a threat to individuals by that point. We also found that for COVID cases early on in the pandemic, there was huge variability with these massive confidence intervals in terms of where the people were actually affected psychologically by seeing these very high levels of cases. And presumably this was variations in whether people, how seriously people were taking it and how serious they thought it was as a virus. But instead, what was a much stronger predictor of people's mental health was how stressed they actually were individually about catching COVID. So regardless of how high the levels were nationally, if you were particularly worried about COVID, this was what was especially associated with depression and anxiety levels. So what this really showed us was there was a much more nuanced picture than we'd ever estimated at the start of the pandemic of what the factors were that were going to drive people's poor mental health experiences. And particularly, we saw that these changed contextually as the pandemic evolved, and particularly as social restrictions changed. So this is one of the big topics that we've explored in a lot of detail, quantitatively and qualitatively, focusing on different subpopulations and looking at the drivers of mental distress in more detail during the pandemic. But I want to turn to think about the issue of inequalities in a little bit more detail. So far, we've been presenting data that's shown overall averages, but of course, not everyone is the average. Now, during the start of the pandemic, you may remember there was this rhetoric around the idea that we're all in this together. And this is a phrase that became pervasive, but actually is really quite problematic. And this is something that we've shown through further analyses that we've conducted. So in this study, we went right back to focusing on the first 4 months of the pandemic when we had that first lockdown. And we wanted to actually see what was the breakdown of different trajectories in mental health that people had. So I showed you before that there was this relationship between sort of higher levels of depression and anxiety at the start of lockdown that then came down. But actually, what was happening underneath these averages? So what we found in these graphs is that around 3/4 of the population followed these red lines for anxiety and depression. So they seem to have heightened symptoms at the start of the pandemic, but actually these decreased during lockdown and as lockdown was eased. So that 3/4 equates to about 40 million adults in the UK. But we actually found there were different patterns for the rest of adults. So we found that for anxiety, about 1.8 million adults actually followed this much steeper trajectory. They actually had particularly heightened symptoms of anxiety at the start of the pandemic that really did improve quite a lot when lockdown came in and continued to ease afterwards. But there were some other groups that had more concerning patterns. So about 3 million adults actually followed, 2 million adults, followed the yellow line that you can see here. So they actually got worse during lockdown and only started to improve after lockdown was eased. And about 3 million adults followed these blue lines here, where they actually got worse during lockdown and continued to get worse even after lockdown had ended. So what this shows is that actually there were some groups where we weren't seeing this improvement from the start of the pandemic. And it also showed that we were not all in this together. There were in fact quite a lot of inequalities in terms of how people were being affected. So I want to consider what some of these inequalities were. One of the things that we saw were clear inequalities based on age. So unfortunately, we found that younger adults had consistently higher levels of depression and anxiety across the whole of the pandemic. And this is interesting because actually at the start of the pandemic, you might remember there was rhetoric around the idea that older adults were the ones who were going to be most isolated and most badly affected. Whereas in fact, what our data showed quite quickly was that it was a more complex picture than that, and younger adults were being particularly adversely affected. We also saw inequalities based on gender. We found, for example, that women had higher levels of anxiety and distress, and this particularly seemed to be driven by stress around catching COVID during the pandemic. We also found that women, unfortunately, bore the brunt of a lot of the effects of the pandemic more than men. So, for example, they were disproportionately affected by childcare and housework increases. They were more concerned than men about things like unemployment, future lockdowns, the economy. More women were employed in sectors that were worst hit during the pandemic. And there were also specific challenges, for example, around maternity services and new mothers. And this echoes what we'd then seen with age. In other words, we were seeing that for younger adults, there were particular life course perspectives that were meaning they were being worse affected. For example, many younger people were being hit during formative years, including transition years to university or to careers. They were more likely to be affected by redundancies, financial problems, living in unstable accommodation. And many younger adults were also more concerned about the longer term implications of the pandemic. So these multiple factors for gender and age seem to underlie why we were seeing these inequalities and experiences. We also found inequalities based on mental illness. So people who had a pre-existing mental illness were more likely to be adversely affected across the whole of the pandemic. But interestingly, we actually found that these same individuals who already had a diagnosis were more likely to seek out formal and informal support. And this was an encouraging factor to suggest that they knew that they needed to be finding additional coping resources, particularly given existing coping resources, things like social support, work, have been disrupted for many people. We also saw inequalities by socioeconomic position. And interestingly, we found that this was a threefold problem. First of all, we found that people from lower socioeconomic backgrounds were most hit by adversities such as loss of jobs, bereavement, financial troubles, difficulties accessing food or medication. They were also more likely to be worried about those adversities happening. So even before they experienced those things, there were preemptive stresses relating to the anticipation of those effects. But what we also then found was that the relationship between these worries and these experiences was stronger amongst people from lower socioeconomic positions. So in other words, it was having more of an impact on mental health than people who had more of a financial buffer around them. Similarly, we also found a number of inequalities based on ethnicity. What we did in our analysis is we were able to run analyses that adjusted and unadjusted for socioeconomic status. And we found that the inequalities persisted even when we'd taken socioeconomic status into account. So this suggests that the findings weren't merely the product of disproportionate experiences of poverty, for example, amongst ethnic minority groups, but instead there are a number of factors that our qualitative research pulled out as being particularly pertinent for explaining these differences in mental health. And one of the things that emerged was a higher experience of discrimination amongst ethnic minority groups. For example, we found in our surveys that around 1 in 4 people experienced some form of discrimination early on in the pandemic based on age, gender, disability, or ethnicity. But actually, these experiences were nearly twice as high amongst people from ethnic minority backgrounds. And this builds on a substantial literature showing the psychological impact of discrimination on mental health. But as you've probably seen from all of these factors, none of these are particular surprises. We know that all of these factors lead to inequalities in mental health outside of pandemics. But what we were particularly seeing during COVID was there was an exacerbation of the inequalities based on these different factors in mental health. So in our papers and reports, we've gone into a lot more detail, not just on these groups here, but also on other marginalised and vulnerable groups, including key workers, parents, people experiencing homelessness, people who inject drugs, people experiencing domestic violence, and people specifically experiencing discrimination. And we've also explored issues of intersectionality quite a bit, highlighting how often it was individuals who were facing inequalities based on one factor were also experiencing inequalities based on other factors that meant they were a member of multiple vulnerable or marginalised or unequal groups. And this seems to have particularly exacerbated effects on things like mental health. Another topic I wanted to touch on today that we really explored in the study was looking at behavioural change during the pandemic. It was a very interesting topic to look at because, of course, we didn't know how people were going to respond to things like long-term lockdowns. So we were able to track factors such as physical activity and also social and neighbourhood behaviours. This included looking at things like eating, drinking, gambling and smoking and other health behaviours. And we found that during the first lockdown, there were quite a lot of negative effects on health behaviours. So, for example, we found that lots of people reported being less physically active than normal. We particularly saw that there was quite high levels of people who weren't even managing to get 30 minutes of daily activity. We also found that 17% of people reported that their diet quality had worsened during that first lockdown, which was compounded by challenges in accessing food early on. And we also identified that there were spirals of gambling and addiction and drug use behaviours amongst some individuals that were exacerbated by lockdowns. But there were also some health behaviours that were a bit less predictable and less clear cut. So, for example, we found that a quarter of adults drank more alcohol during first lockdown and a quarter drank less. What we did see consistently, though, was that the groups that changed their behaviours were the same groups I've just highlighted who were experiencing inequalities in mental health. So things like young people, women, people who had pre-existing mental health problems. So this suggested that for these individuals, there was a less stable behavioural base that they were operating from during lockdown. Similarly, we also saw changes in social behaviours. So, for example, we found that many people changed their attitudes to neighbourhoods during the pandemic. About a third of respondents said that they experienced an improvement in their neighbourhood relationships in the first year and a half of COVID. But at the same time, satisfaction with neighbourhoods actually went down. So, for example, satisfaction with the quality of green space, with neighbourhood safety, with walkability. About a third of people said that they became less satisfied as they actually got to know their areas more during lockdowns. We also found changes in things like volunteering behaviours. So, for example, about 23% of people decreased their volunteering behaviours during the pandemic as ordinary opportunities were reduced, but we actually saw an increase of about 12% engaging in novel types of volunteering. So, for example, getting involved more in social science research during the pandemic as people saw opportunities for altruism. What was interesting as well, though, was not just this change in the percentages of volunteering, but actually the fact that we saw greater representation of certain groups who normally don't get involved in volunteering as much, including individuals with pre-existing mental health problems. We also saw changes in other behaviours such as arts and cultural engagements. We found that during the first lockdown, many people actually increased their home-based arts activities for a number of reasons, including having more time and greater availability of digital and online opportunities. But actually, we found that many of these behaviours actually returned to more normal levels when lockdowns eased. So we were seeing essentially short-term behavioural modifications that were brought about by these very specific stay-at-home orders. We also looked at the relationship then between lots of these different behaviours and people's psychological experiences. So just to look at 3 of these different factors, one of the things we looked at was changes in people's social and neighbourhood support and their social connections and social cohesion, and their mental health. And what we found was that although there were some benefits from things like phone and video contact for reducing things like depressive symptoms, which is what this graph shows, we actually found there were stronger associations if people had face-to-face contact. So this was suggesting that the kind of virtual and digital offerings that people were trying to make the most of during the pandemic actually didn't have the same kinds of benefits that good old-fashioned face-to-face contact has. And in fact, we also found that over time, people who spent large amounts of time, so more than 2 hours a day, using text messaging or video messaging, this was actually associated with worsening symptoms of depression and anxiety, which seemed to come about from our qualitative research through people actually feeling more disconnected sometimes from these less natural, more artificial experiences. But we also found that having social support, even if you weren't drawing on it, actually was associated quite strongly with much better mental health. So just feeling there were people around you who could help was really important. We also looked at arts and creativity and mental health. And of course, the arts had quite a lot of prominence due to things like people singing from balconies during lockdowns and painting rainbows for the NHS and watching live streamed theatre performances. And we found that all of these creative activities were associated beneficially with mental health. So if people increased their engagement in these activities, that was subsequently followed by decreases in depression and anxiety and improvements in well-being. And we also looked at nature and outdoors engagement, particularly during lockdowns. And of course, people were allowed to go outdoors for exercise, even if it was at certain lockdowns limited to once a day, but not everybody made the most of that opportunity. But we found that for those people who did, the more days a week they actually went outside, the better their mental health was. But notably, these associations were strongest when people had greater satisfaction with their neighbourhoods. So this really highlights that it wasn't just about having fresh air, it was also about feeling some kinds of psychological benefits from the kinds of natural environments that people were able to engage in. So these are just 3 examples of protective behaviours. We've also looked at a wide range of other health and social behaviours, including substance use, diet, alcohol, smoking, health service use, education, work and relationships. And we've detailed in our reports and papers how all of these factors were associated with psychological experiences too. But we also extended our psychological work to try and understand more about experiences of long COVID. We conducted very early research into how people experienced long COVID and particularly experienced care for their long COVIDs. What we did find was that like short COVID, so regular COVID illness that people recover from within a few weeks, there were certain groups who were more likely to be affected, including those from lower socioeconomic backgrounds, those with lower educational attainment or with existing physical or mental health problems. So again, the same kinds of inequalities that I'd already spoken about that were affecting people psychologically. But what we found was that the symptoms that people experienced from long COVID, coupled with a lack of services and treatment options, were leading to rather negative illness trajectories, and particularly a lot of uncertainty around what kinds of illness trajectories people could expect. And this was really also affecting people's identity. We did find that having care and understanding from others could help to support people's experiences, but for many, feeling unheard was actually exacerbating these symptoms. And this actually brought us into thinking a lot more about the psychological experiences of long COVID. What we actually found was it wasn't just that these psychological experiences were happening after people had had their diagnosis of long COVID and therefore had had these changes in experiences, in healthcare utilization and in identity. But we actually found that psychological symptoms were happening much, much earlier in long COVID. And in fact, what we discovered was that in the first week of contracting COVID, people who were going to go on to get long COVID were already experiencing different trajectories of anxiety and depressive symptoms. And this is really interesting because it suggests that some of the psychological symptoms of long COVID may actually have their roots in some biological pathways. So for example, you can see here that symptoms of depression and anxiety actually emerged almost immediately after infection, both in long and short COVID sufferers. So we can see this immediate jump from levels just before people had COVID. But we found that these jumps were much bigger in people who were going to go on to have long COVID. Now, we know in particular that depressive symptoms are interconnected with inflammatory immune responses, which have been shown to rise following infection with COVID. So what this actually supports is broader research that's been coming out biologically, suggesting that there could be an immediate inflammatory response caused by the virus that actually increases the risk of certain individuals going on to experience long COVID. We also found that people who went on to have long COVID actually had heightened depressive symptoms for the months that followed. And you can see that these symptoms actually lasted 2 years, so over 20 months, after the initial onset of infection. And we're still seeing this particularly large gap between the long and the short COVID sufferers at this 2-year follow-up. And we also found that individuals who went on to get long COVID had anxiety symptoms that really didn't show any improvement over that 20-month period. So this led to widening differences in anxiety between those people who had short and long COVID. So this complements what we were finding qualitatively from the previous slide, because it suggests that some of these widenings, for example, may well be due to the changes people were then experiencing as a result of having long COVID, like changes in their work patterns, their socializing, their healthcare and their identity. But we're actually able to see that the onset of these issues is happening almost immediately with COVID infection, which tells us a lot more about the mechanistic pathways involved in long COVID. And we've extended this work by actually looking at other pre-infection factors that are associated with an increased risk of long COVID. And this includes people having poorer sleep quality in the lead up to catching COVID. People who had poorer sleep in the month beforehand were more likely to get long COVID. And we know that sleep was one of the biobehavioural pathways that was linking stress with adverse psychological effects in the pandemic. So this suggests that actually stress in the weeks and months before COVID infection could also increase someone's risk of developing long COVID. And the final topic that I wanted to talk about today, which was another key theme of our research, was looking at people's compliance with regulations, which of course was a major issue during the pandemic and of course is vital to the management of all infectious diseases. So we started tracking people's compliance with the guidelines right from the beginning of first lockdown. And actually what we found was that contrary to initial policy concerns, when you might remember there were lots of discussions about things like behavioural fatigue, this idea that we'd all get bored and stop complying, we actually found that this wasn't the case. We found that majority compliance with the rules, so in other words, largely following them, was 97% during the first lockdown and remained above 80% across the entire pandemic. And we found that there were lots of reasons that people were happy to comply, including wanting to protect family and friends, feeling a sense of social responsibility, believing it would bring the pandemic under control, and also helping people to feel united in a shared identity. But there were lots of different factors that actually acted as barriers to people being able to comply. And this included things like people's living environment, their ability to work from home and remain connected to family and friends, and whether or not they had the support of support bubbles. We also particularly were interested in demographic predictors of compliance. And as we found with drivers of mental health, we found that drivers of compliance really changed across this pandemic, which wasn't anticipated so much early on. So for example, we found that people from higher socioeconomic backgrounds actually had better levels of compliance initially in the first lockdown, perhaps because they were more able to comply. For example, they had Wi-Fi so they could work from home. They had more access to things like garden space. They had the means to get food deliveries. But actually what we found was that later on, individuals who came from higher income backgrounds actually started having lower levels of compliance. They actually didn't follow the rules as much. And it's possible from our qualitative research, it seemed that there was a sense of privilege coming into play, that individuals perhaps didn't believe that the rules applied to them, or they felt they could judge the pandemic situation for themselves. And we found this pattern actually across a number of other factors as well, that things that initially predicted people's compliance actually went on to have a greater effect as the pandemic continued. And what this suggests is that early on, people were very good at following rules because they saw the need for it very, very clearly. But as the rules became more ambiguous, and also as people started to experience a slight lessening of their own self-control or boredom increased, then individual characteristics, these kind of demographic characteristics, actually started to override the desire to follow guidelines. And it was only later on in the pandemic we started to see a much clearer patterning of people's compliance based on these demographic factors. We also looked at the relationship between compliance and trust in the government. And what we found, of course, was that there were a number of key events, for example, the breaking of lockdown rules by Dominic Cummings, that actually corresponded with clear decreases, both in confidence in government and also in compliance in the weeks and months that followed. We dubbed this the Cummings effect. And what it highlighted was that there was a close relationship between public trust and compliance in the actions of our political leaders. And in fact, what we found was that trust in government was a much bigger predictor of compliance than things like mental health, as well as things like belief in the health service or numerous other factors. So this really highlighted how dangerous the concept of leader exceptionalism was. And it really reinforced a number of social psychology theories that have highlighted the importance of collective citizenship and social unity during pandemics. We also looked at compliance in relation to vaccination. And we found that in the autumn of 2020, just as the first vaccines were going through trials, nearly a quarter of participants actually were unsure about being vaccinated, as they had some kind of general mistrust around vaccines, about whether they would work, whether they were safe, and whether they actually would simply be carried out for commercial profiteering. What we found overall was that predictors of being unwilling or hesitant to have a vaccine were related to a heightened risk of COVID. So unfortunately, the same individuals who were unwilling or hesitant also had lower levels of compliance and also had health risk factors. Fortunately, what we did actually find was that there was little evidence that once people were vaccinated, that they changed their behaviour. There was initially a worry that once you'd had your vaccine, you wouldn't bother to follow the rules as much. And in fact, we didn't see that at all. We actually found that both general compliance and social distancing were maintained even after vaccination. And we followed up vaccination in a year and a half that followed. And we found that if people had actually been hesitant initially, even if they went on to have their first 2 vaccines, they were 5 times more likely to be uncertain or unwilling to accept a booster. So this really highlighted how pervasive vaccine mistrust can be. Even if we can overcome that with early behaviours, it can actually go on to have longer lasting effects on people's likelihood to comply with future measures. So compliance and vaccination have also been major focuses of our research, and they're summarised more in our report and papers. But I want to conclude by just touching very briefly on what the impact of all of this research has been. This is something that we talk about a lot in our final reports. And we've broken this down into different sections, including showing what the policy impact has been. And there are really clear examples of how the data from this study has been used to inform Cabinet Office, government departments, the NHS, World Health Organization. We've undertaken a lot of presentations and contributed to ministerial and public health dashboards across the pandemic to make sure that the data that we've been producing have been getting to decision makers throughout. We've also engaged with a lot of different task forces, including Lancet and WHO task forces and government office task forces in the UK to support decisions that were being made. And our data have informed both NHS service planning, and also they've been cited in over a dozen different SAGE publications to help with decisions like when to ease lockdowns, what financial support packages were needed, whether mass testing should be enforced, and how to design the vaccine rollouts. We've also had very clear community impact, including supporting suicide prevention through national committees and through the Samaritans, supporting decisions around public mental health campaigns, helping the Red Cross with their vaccine rollouts, and supporting local authorities in designing strategies and allocating funding during COVID. We also have had individual impact. We've had 85% of participants saying they felt it was worthwhile. And there are some wonderful case studies that have emerged of people actually modulating their own behaviours as a result of taking part in the study, because they were becoming more aware of things like their mental health and actually using the study as a barometer to track how they were doing week by week. And we also had international impact. We informed the development of sister studies through the World Health Organization in 33 other countries. And we also ourselves helped to establish studies in 8 lower middle income countries through sharing all of our study protocols and data dictionaries and providing pro bono consultation to those research teams. We also formed special interest groups and contributed to various commission reports around the world. And as I mentioned at the start, we've been doing increasing numbers of international comparisons looking at how the UK data compare to other countries. A major step is that we have now also published our data as of yesterday on the UK Data Service. So this is now available to other scientists and academics who want to work with it in the future. So we're hoping it'll be a resource that continues to inform social science over the coming years. But I just want to close by considering what is it that we can learn and do as a result of all of the findings from the study. And in our report, we've made 7 recommendations. The first of these is we need to tackle entrenched social inequalities, because these are clearly problems outside of the pandemic, but also were exacerbated and really widened issues during the COVID-19 pandemic. And given that, of course, there will be another pandemic at some point, it feels pertinent that we actually try and capitalize on these issues now and address things ahead of that. The second thing we've recommended is to invest in mental health services. And we've argued this is particularly important because in this graph at the bottom, we've shown a very basic interpretation of what we think is going to drive mental health. We've initially had fears and responses to the pandemic, followed by immediate responses to adversities that people have experienced as a result of the pandemic. But we're now heading into these new phases, including the fact that many people haven't been able to access mental health support when they've needed it, meaning their experiences have probably got worse in the last couple of years. And we're now heading as well into the longer term consequences and byproducts of COVID, including things like recessions, unrest and poverty and broader geopolitical events. So it's going to be really important to make sure that we're preparing to address these secondary effects, rather than assuming that just because virus levels or deaths might be going down, that there might in some way be a natural resolution of mental health. We've also recommended expanding community-based support, particularly focusing on the kinds of community assets like green spaces, culture, social activities, leisure. And we've recommended an increase in schemes like social prescribing that are helping to provide alternative options as opposed to simply increasing pressures on the health service. We've also highlighted the importance of embedding transparency and integrity in health policy, particularly given all the results that we've seen linking people's behaviours with public trust during this pandemic. And we've also highlighted the importance of really clear and effective communication on health issues from policymakers. We've also recommended investment in social and behavioural research, including continuing to develop existing large-scale cohort studies, but also perhaps being ready to go with studies such as this one in the future, so that in the next health emergency, we've got plans already in place that we can mobilise to capture some of the finer grained details of people's experiences like this study was able to. There's also a very clear need to foster social solidarity and social cohesion. We found early on that social support and a collective social identity really buffered some of the adverse effects of the first lockdown. But unfortunately, it's now become much more a case of social divisions in this country. And we know this has negative effects on mental health. So we're calling for there to be much more of a collective social identity as we work to move beyond the pandemic. And finally, we know we need to plan for the next pandemic or health emergency now. And there are so many very specific aspects of learning that we've outlined in our final reports. We're asking now that these are developed into specific plans so that we can try and minimise the adversities that the UK public and other countries' publics face in the event of future health crises. So overall, as I said, this has been a slightly whistle-stop tour, but you can see more information both in our new impact reports and also in our study websites, which include details about how to access our data as well. And I really just want to end by thanking the study team. This was a hugely collaborative effort from my research group at UCL, as well as very, very close work with external collaborators and our steering groups. Obviously, none of this would have been possible without the phenomenal efforts of our participants who've stuck with the study with very high retention rates over the last 2 years and have contributed so honestly and freely about their experiences. And last but definitely not least, I'd love to thank our funders, including Nuffield, as well as the Wellcome Trust and UKRI, who provided incredibly rapid and phenomenal support across this pandemic, and obviously without whom none of this would have been possible. Thank you very much.
Thanks, Daisy. Terrific presentation. Lots of great feedback in the chat and lots of good questions to be looking over in the Q&A. I wonder if, well, there's going to be more questions that I'm going to be able to round up in this little 15 minutes that we have now. But I'm going to give you an advance warning that I would like to finish this Q&A in about 10-15 minutes time with a question which is a slightly more specific version of the way that you ended up, where you were thinking about the lessons going forward. I sit here in my kitchen with COVID, ironically. It's quite clear the pandemic isn't over yet. We're about to go into a winter with an even more stretched NHS and potentially a COVID and bad flu. So, I mean, are there more specific lessons that you might be able to draw from your study for the government going into this winter? I'll leave you to germinate on that for a little bit in the background while we deal with some other questions that have been coming up through the chat first. So let's get in. I'd like to begin by talking about mental health. I think obviously that's a very important part of some of the early findings and a sort of key thread that sort of fits through everything. Some questions in the chat and some of my own thoughts really about sort of resilience and the trajectories and bounce back and all these various different things. You showed a big initial effect on the young, but I think, from what I know, actually the longer term effects were maybe more focused on the old and middle ages, and maybe the young might have bounced back probably slightly more. There are nuanced effects around women, for example, with the nature of exactly how these mental health effects were timed relative to school lockdowns and various different things. And then there's this issue of sort of resilience in general, about whether certain types of people have more ability to bounce back because of their sort of past, if you like, whether that's past experiences of COVID or past experiences of things even before COVID. So I guess what do we take from all this? I mean, we did see these initial, strong adverse effects. Did certain groups of the population bounce back to actually where they were before, even higher than where they were before? And how do we think about these trajectories more generally?
Well, I think thinking about multiple trajectories is what's really clear here, which is really important here, because we can't just look at averages if we're really going to understand the different experiences of people. So, of course, there are some individuals who have bounced back. And in fact, we do see that as a species, as humans, we're very good at actually adapting to events, whether positive or negative, that happen in our lives. And that's one of the reasons that we often see from studies outside of pandemics, that when people face either highly positive or highly negative events, a couple of years later, you can actually find that they're back to very similar levels of well-being. So this sort of hedonic treadmill effect, as it's sometimes called, is something that we have seen played out in the pandemic, particularly during lockdowns. And this, of course, counteracted some of the initial predictions, which were that lockdowns would universally lead to poorer mental health week on week the longer they were in effect. And that actually wasn't what we saw, as you saw from the graphs. That was only a small percentage of people where that actually happens. But at the same time, there are some other groups where we've not seen that same bounce back. And I think what's been particularly challenging, if we think about this as a natural experiment, is that it's not just been the pandemic. The pandemic has now evolved into cost of living crises, into geopolitical events like the war in Ukraine. And these other events, of course, do have effects on people psychologically, upcoming recessions and things. We know those have very strong effects on mental health. And the challenge is going to be trying to separate out the people who haven't bounced back. Is that because there was some kind of individual trait that's prevented them from bouncing back? Or is it because these other events that are now coming into play are actually starting to take their toll? And at what point are we attributing some of these events to the pandemic itself? And at what point are we attributing them to just being parallel events that might be separated? And that's what's going to be difficult, I think, to disentangle some of those different trajectories over time.
And indeed, presumably, events that have happened in people's lives or to their, to groups around them in their lives even before the pandemic are going to generate a certain amount of resilience or exposure as well, right? I mean, did you try and measure some of those exposures, if you like, in your survey? Had you got historical data on pre-pandemic?
We did, actually. We asked people about adverse experiences in the 12 months prior to the pandemic. And of course, there was, as expected, an association between having, I guess, what would probably be seen as a decreased resilience based on prior adversities and being less able to cope with the new adversities and experience that then struck during the pandemic. And of course, that echoes lots of previous research on life stresses and adverse childhood events and things, and looks at how those things can negatively affect resilience across the lifespan. So that certainly echoed what we'd seen outside of the pandemic, yes.
So I suspect lots more written on that in some of those papers, and indeed more research that could be done, presumably, with the data on those.
Absolutely, and we've got more things on that in press at the moment too.
We have a number of questions, just really trying to dig a little. I mean, obviously, you were only giving a summary of your results today, but talking about the fact that you have such an incredibly large sample, such incredibly high frequency observation, that you really could dig quite deep into, if you like, the heterogeneity within the population. So not just differences between men and women or differences between white and non-white, but differences by ethnic groups, or differences between, for example, lone mothers and lone fathers in their experience of stresses and strains related to childcare during lockdown. Are those kind of differences explored already in some of the reports that you've been quoting, or is that something that researchers would need to go to do more with the data in the future?
It's something we've done to a certain extent, but when we were deciding what questions to prioritise in the last year, we were really driven by what requests were coming through particularly from policy in terms of what was going to inform decision making. So a lot of that, I guess, unfortunately means you end up looking at quite broad brush categories. And there are some things where we've applied binaries, as you said, between, for example, white and ethnic minority groups or between men and women, that of course aren't accurate descriptions of different groups. And I should highlight that as well as binary descriptors, for example, of gender, we've also got broader categories that go beyond binaries within the data sets. But that's really one of the reasons that we wanted to open this data set up to other scientists, because we're aware that now we're moving beyond that initial policy making stage. We've actually got a huge amount of data that will be able to talk about those nuances of experiences for subgroups that will be both relevant scientifically, conceptually, but will also have huge relevance for planning for future pandemics. So it's not something we've not done enough on yet, and it's something I'd really encourage others to use the data set to explore.
Terrific. I'm an economist, as you know, and so economists both believe in the market and the wisdom of crowds. So I think it's my duty to ask the question with the most votes, which is from Bob Oliver, which is, what was the main surprise from the surveys, and which conformed, and what conformed most to your expectations? One finding from each, if possible.
I think the thing that was the biggest surprise is probably that we were still conducting the study 2 years later. As Nuffield will know, our initial application was to stop the study after 24 weeks. So it was a bit of a shock that actually we were going to see so many lockdowns and such a continued relevance of collecting this data. I guess more specifically, a big surprise was seeing how people responded to lockdowns and how that differed from previous epidemics where we'd had quarantine data, again, like I was saying earlier, suggesting that there have been worsening experiences during quarantines. But in fact, we were seeing quite different patterns during lockdowns for a pandemic compared to quarantines for an epidemic. And I think as well, seeing the changing predictors of compliance, of mental health, seeing how contextual factors really moderated those over time. So realizing there wasn't one pandemic effect per se, but a real need to consider sort of wider ecosystems approach when we're considering these sort of very complex global events. I think the thing that was the least surprising was probably the work on inequalities, seeing that the same patterns of inequalities was exactly what was happening outside of the pandemic, but we were just seeing this exacerbation of the effects. And I think that's something that's always very frustrating when you can see something bad coming and happening, but we're still not tackling those things in society that need to happen to address that ahead of the next disaster.
Yes, and that indeed was very true in the economic domain as well, I think. There was a few questions that came in predominantly in advance of the seminar, but also related to the questions in the seminar, thinking a bit more about the longer term effects probably. And you just spoke now about the contrast of this pandemic to different previous epidemics. And I wonder, is there anything that really comes through in your analysis about the longer run effects, if you like, on social institutions, people's engagement? You spoke about an increase in volunteering for some people, a decrease in community participation for other people. Obviously contrasting this pandemic to previous pandemics where we didn't used to have the internet, or we didn't used to have global everything else. Are there lessons, do you think, that we can learn, or about the longer run effects on sort of community and social institutions?
It's a really interesting question. And of course, something that happened with the lockdowns was that they were long enough that we were going beyond a few weeks. It was long enough that you actually could set new behavioural patterns and routines that were likely to stick for longer time spans. And we saw that, for example, in health behaviours like physical activity, sometimes not bouncing back when lockdowns had ended because people had got into new inactive patterns that were then quite hard to shift. I guess in terms of these sort of broader social institutions and engagements, it's challenging to see. We have noticed changes in attitudes towards things, and we asked a lot across the pandemic about people's attitudes and what their plans would be of whether they would be changing their lives post-pandemic. But actually, over time, we've seen these effects have waned quite a bit. So initial resolutions and plans that people have made broadly haven't been followed through to the same extent longer term. So I guess that leads me to think there probably isn't going to be the same kind of seismic shift we initially were kind of hoping that there might be. The fact that everyone would know their neighbours and be much more community connected, people would sort of change their priorities in life. There's certainly been a certain amount of that, but I don't think it's been the seismic shift that perhaps some of us were hoping for early on.
Indeed, when you were presenting it already seems a long time ago, the pandemic, in terms of what we are now talking about. But it's interesting how those trends will work out. So let's come to the shorter run in that case. You know, where do you think the main lessons lie? I mean, you've given us, you know, your long run lessons. One can't argue with in terms of thinking about health inequalities or thinking about the provision of mental health services. But is there, you know, you were in the field, you know, uniquely every week in a time of acute stress and strain, both on government policy and on the health service and on local social services and local labour markets, actually. You know, so I guess we probably won't go through those kind of same things this winter, even if we have more and more waves and more variants. But are there lessons that we can take for, you know, the next 12 months going forward, when we combine, as you said, further waves of COVID with cost of living and energy prices and everything?
I think there'll be some things that we don't see anymore. So as I showed early on in that graph about the drivers of mental health experiences, the relationship between high cases or high death rates from COVID seems to have been broken with mental health. So I don't think we're going to see those same kinds of effects unless we see a clear new variant that starts to have very different patterns of infection and mortality. But I think it's probably going to be those broader societal factors that have now become the key drivers of mental health. And I think the other thing that is likely to become an increasing driver of mental health is people's experiences of healthcare. So obviously we're seeing a lot about burdens on the NHS, long waiting lists, things being cancelled, staffing issues. Those things I think are going to start building up, both in terms of the psychological anticipation of having services that perhaps then aren't going to be there, but also in terms of people having care that gets cancelled, and either that being mental health care, which then means that they're on waiting lists or whatever, that they're deteriorating in the meantime, or physical health care. And given we know the relationship between physical health and mental health is so strong, we have to remember that any cancellations or delays to physical treatment is also going to have psychological implications. So I think it's going to be thinking a lot more about those broader social and financial factors, but also the impact that the health service effects are going to have psychologically on the population.
And just to a specific follow-up that, because I was very interested where, you know, in one of your findings where you were talking about the people who were worried about COVID had the worst mental health outcomes. I mean, it's not actually as tautological as it sounds, I think.
No, it's a chicken and egg bit.
Exactly. But I think, so the question is, you know, are there specific things that one could do with mental health services to the people who have the worries and the stresses, or is it something that you just need to provide mental health services when the anxiety and depression happens? It's like, as an economist, I think of it, is there kind of an insurance role for the health service as well as an actual treatment role?
Well, that's why we're proposing this sort of dual approach, where as well as investment in mental health services, it's clear we need to have more investment in things that we know can have a preventative effect. And that's often around sort of community infrastructure and social infrastructure that supports people. And mechanisms like social prescribing can help refer people between those two different options. But I think we have to be thinking pragmatically that we're not seeing the level of investment that we know we need in mental health services. We have to be thinking more about what can be done through other services to support people psychologically over the coming months as well.
Yes, absolutely. I think that's a good place to know. I think if one thing the pandemic has taught us is that I think we agreed on it pretty early with the policymakers, is that we do need to think more about mental health. And actually, I think now with long COVID, we also need to think more about sort of these complicated, rather difficult to pin down autoimmune type diseases as well, right?
Definitely.
So I think those are two sort of generic lessons that we probably, hopefully, will take forward in the way that we think about health and economic and social policy. Listen, Daisy, this is a terrific session, and we could go on talking for many, many minutes, but I know people have to leave. We said we would finish at 3. So it's all just my final duty to thank you ever so much for the research, for the great presentation today. I'll tell all the participants that obviously the links to the research are in the chat. You can download the slides. Obviously, you can follow up the papers. You can download the data and write your own papers. And within reason, you could email Daisy and her team some of these specific questions that I haven't had a chance to ask for you, and they may well be able to point you to more specific answers. So thank you, everybody. And with that, I'll close the webinar.